None of this should be new. We already covered this last semester, but I'm going to go through it again because it'll help you be able to review the sleep studies that you have staged, to be able to go back and determine if they're kicking, if they're having respiratory events, anything like that. So PLM, periodic limb movement. So the following defined a limb movement event. It's got to be a minimum of a half a second long with no longer than 10 seconds. The minimum increase is an 8 microvolt increase above your resting voltage level. As you probably have picked up, there aren't really voltage meters on our system. So the basic thing is you need to know that it's 8 microvolt because they'll question you and test you on the standards and the criteria. But the thing is, do you see a leg movement or do you not? Is it like a twitch, which would be less than a half second long? Then that doesn't count. Or is it overt body movement? Because that typically is longer than 10 seconds. That wouldn't count. And then the timing of it, so just like with the arousals, it's not so important to mark and drag and spend time clicking and dragging the entire event, but it is important to try to time the beginning of the event. So that's the point at which there was that 8 microvolt increase. And then the end of the event is the period that where your leg muscle tone returns back to resting EMG or is within 2 microvolts above EMG. The thing with this is these are the rules. They're kind of, but leg movements, you either see them or you don't. They're very clear. You got a leg movement or you don't. It's not like chin EMG where you have these more kind of increase in tones and then back down in tones. That's why we have these rules in the very rare instances that you might have something like that. But with leg movements, you either have a kick or you don't. So we aren't spending time marking every single leg kick unless if it's in a series. And what defines a series is that you have a minimum of 4 leg kicks separated by no less than 5 seconds, but no more than 90 seconds. And if you have 2 leg kicks on 2 separate legs that are separated by less than 5 seconds, they're counted as a single leg movement. Let me say that again. So with leg kicks, you are marking leg kicks if you see a clear leg kick, but you have to have at least 4 in a row. Otherwise, if you have a random leg kick, you're not marking it. It's not going to be counted towards the overall number. So you know how when you tabulate your data at the end of scoring something, it gives you the overall number of leg movements? Well, you're not marking these random leg kicks. You're only marking them if they occur in a series. And what defines them as being in series is they're separated by at least, each leg kick is separated by at least 5 seconds, but no more than 90 seconds. So if more than 90 seconds is between one leg kick and the next, you don't count them unless if there's 4 within. It doesn't all have to be within 90 seconds, you have to have 4, but between one and the next, you can't have more than 90 seconds separating each of them. Does that make sense?
Yeah.
Yes. If they're not in a series, you're not marking them. You're not marking random leg kicks. You are not marking a leg movement if it occurs in conjunction with a respiratory event. Oftentimes what happens with an apnea or a hypopnea is a person will kick themselves awake. Is it truly a leg kick then? A scorable, diagnosable event? Or is it more a symptom of the respiratory event? Right? That's why you are not marking a leg movement if it occurs within preceding or within a respiratory event. It's not a true leg movement. It was a result of the respiratory event. When a leg movement and an arousal, an EEG arousal, are occurring within a half second of each other, we can say that they are associated with each other. Either the arousal caused the leg kick or the leg kick caused the arousal. That's why I said it doesn't matter how long the arousal occurred, but just try to be as precise as possible with marking the start of the arousal, because that's what you want to look at. If you have a leg kick and arousal, which came first? If the leg kick came first and then caused the EEG change, you can say that is a PLM arousal, an arousal as a result of the leg kick. If the arousal came first and then you have a leg kick, then you can say that the leg kick is a result of them waking up, not a scoreable event, right? Because it's not a diagnosable disorder when they're just kicking or moving because they just woke up. You're not going to spend time marking limb movements unless if they meet the limb movement criteria, meaning they're at least a half second long, they're not more than 10 seconds long, and they are incorporated within a series, that there's 4 in a row. They're separated by each of these limb movements. Each of these 4 limb movements are separated by at least 5 seconds, no more than 90. But if you have these isolated leg kicks, you're not going to mark them. You just leave them be. Bruxism. There's a couple different types of bruxism that you can see, which is teeth grinding. It can be brief, which is also called phasic, meaning you'll see these like phasic twitches in the EMG muscle, or sustained or tonic elevations of the EMG muscle activity, meaning they're clenching down and they're staying clenched for a little bit of time. There's different types of bruxism, phasic or tonic. You can score. I don't think many of my samples have bruxism. But you're going to score it if you have elevations of your chin that are 1/4 of a second to 2 seconds long, and you have at least 3 in a row. That's that kind of phasic twitching of the EMG muscles that are happening in a regular sequence. Or if you have a sustained elevation in your chin EMG for greater than 2 seconds, you have to have at least 3 seconds of stable background EMG before you can score a new onset or episode of bruxism. It can also be scored using audio, by like audibly hearing the teeth grinding, but we don't have that ability or availability on our studies here. The respiratory rules. There are recommendations for what sensor, what channel you're looking at to look for specific events, and also to determine where you're marking these events, where you're marking the start and end of these respiratory events. So you're going off of your pulse ox for the oxygenation level, you're going off of your rip belts for your effort, but you have 2 different types of flow sensors. You have a thermal and your PTAF. The thermal is what you're looking at to mark and identify an apnea. The PTAF is what you're looking at to identify a hypopnea. Do you know why this might be? The thing is the thermal sensor isn't as sensitive as the pressure transducer. It's like you either have airflow or you don't. A pressure transducer is so the thermal sensor, when you start getting used to looking at it, it just it stays, it's there, and it's hard to determine changes and variations in the depth of breathing. A pressure transducer, or PTAF, is very sensitive, and you can kind of pick up the changes in the depth of their breathing, the change in their minute ventilation and tidal volume. So you're able to see if you do have that airflow diminishment that's a requirement for a hypopnea. Because do you guys remember the definition of a hypopnea? 30% drop in airflow. Like, we're not sitting there with calipers, but you do need to see a drop in their airflow to determine that they have a hypopnea. You're not going to be able to see that with the thermal sensor alone. We are really going to be able to see it with the pressure transducer. If you have things that aren't working, then there's backup sensors that you should be looking at. So to score an apnea, your backup sensor would be the pressure transducer. If you don't have rip belts to score the patient's effort, you should be looking for diaphragmatic or intercostal EMGs. What that is you're placing EMG electrodes, muscle electrodes, on the intercostal muscles. So we had to place these for a time, and some labs still do use these electrodes where you actually have the patient lean over, you find a rib as best you can, and you put 2 electrodes 2 centimeters apart right in between the rib to try to get it right on that muscle. One of the reasons why if you don't have diaphragmatic or intercostal EMGs, it's so important to make sure you have valid belt signals coming through. If your pressure transducer isn't working, say the patient pulled the cannula out, your backup necessarily isn't the thermal sensor, but actually your rip belts. You'll find that your rip belts, when they're working well, you can really see these changes in their breathing, that they're pretty sensitive to a patient's breathing, more so than the thermal sensor. But you really got to kind of evaluate all the signals coming through to look at, okay, what's the one that's going to give me the most viable option to look at if things aren't working. So in order to determine where you start and stop scoring the respiratory event, what you're looking for is you're looking for the change in their breathing. Nadir, do you guys know what the definition of nadir is? Lowest point. It just means the trough or the lowest point. So it's measured at the lowest point of the first breath that is clearly reduced, that starts this respiratory event, to the lowest point of the first breath that approximates their breathing back to their baseline amplitude. Let me say that again. How you determine the event duration and where the actual respiratory event occurred is if you're scoring a apnea, you're looking at your thermal sensor. If you're scoring a hypopnea, you're looking at your P-tap signal. But you're starting the event at the lowest, so you know how it's like a little wave, goes up and down, up and down, up and down. You're starting the event, marking the beginning of it at the very lowest point of the first breath that's clearly reduced, and you're ending it at the lowest point of the next breath that returns to baseline breathing. So if we're scoring an apnea, we're looking at our thermal sensor, and you start at the lowest point of the breath that's clearly reduced, and you end it at the lowest point of the breath that returns back to baseline breathing. Same thing for a hypop. This thing is like a little bit shifted. I don't really like these brackets, but you would start it right here, because that's the first breath that's clearly affected as part of this respiratory event, and you would end it right here. The lowest part or nadir of the first breath that's back to baseline breathing amplitude. That's for a hypopnea. This is an apnea. So notice the apnea is going off of the thermal, hypopnea is going off the pressure transducer. When, because this is textbook, when you cannot determine when the baseline breathing amplitude returns because their breathing's crazy wonky all over the place, how do you know when to end scoring the respiratory event? Well, you can either just end scoring it when there's a very clear and sustained increase in amplitude of their breathing, or if there's been a desaturation, if their oxygen level dropped in response to this respiratory event, you can end scoring it when their oxygen comes back up by 2%. That's where you can end it. These are kind of just in case rules. For the most part, you can kind of use your clinical judgment on when, if it's really, really hard, when to stop or where to stop scoring the events. So the definition of an apnea. You're going to score an apnea when you have your thermal sensor drop by at least 90% from baseline. So you might still have a little bit of fluctuation in that signal. The event lasts at least 10 seconds, and at least 90% of the event's duration meets the amplitude reduction criteria, where you have that drop in the thermal sensor for at least 90%. You do not need a desaturation to score an apnea. It's not part of the definition. The basic thing with an apnea is you have a drop in airflow for at least 10 seconds, and that drop in airflow is dropped by about 90% or greater than what it was at. Okay? That's the definition of an apnea. To determine the type of apnea, you're looking at your respiratory effort, or specifically your inspiratory effort. So once you see there's zero airflow or there's absent airflow on your thermal sensor, then you look at your rip belts to determine what's going on there, if there's effort or not. So if there's continued effort, that would be considered an obstructive apnea. Their airway's closing up, but they still have the drive to breathe. Sometimes you'll see that the effort at the beginning of the event is a little bit low, and then it gets bigger and bigger and bigger as they continue to struggle to breathe against an occluded airway. You might also see that paradoxical breathing, that where their stomach and their abdomen are out of sync with each other as they struggle to breathe. Let's do an experiment. Let me come and choke you, and let's see how your stomach moves as you struggle to breathe. A central apnea means that there's no drive to breathe. So when you look at the respiratory belts, there's zero effort to breathe as well. Those are flatlined as well. When you're doing biocals and you have your patient hold their breath, that mimics a central apnea, right? Zero airflow, zero effort. A mixed is a combination of the two. Starts off as central, ends as obstructive. So where's the picture? I have pictures, and I'll come back. There it is. I don't know why I have it all the way to the end. No airflow, continued effort. No airflow, no effort. Mixed is no airflow. So you see how if we were to cover up the bottom, the apneas look identical throughout. Apneas will look identical. You have to look at your effort to figure out the type of apnea. So mixed starts off as central, and then the drive to breathe returns. So essentially what's happening with a mixed apnea, think about it like if you were to do a research paper on all the different types of apnea, obstructive, mixed, central, you'll find a huge chapter on obstructive, you'll find a good chapter on central, and then when it comes to mixed, you'll find a paragraph. That literally is just the definition of it. And what I usually will tell people, the respiratory students specifically have to do a report, is treat obstructive as if it's more, or mixed as if it's more obstructive in nature, because it really is. What will tend to happen here is in between an event or in between an apnea, the patient, what happens is throughout the time that the apnea is occurring, your CO2 is rising, 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 rising. As a result, patients or people will start to hyperventilate to blow off that CO2 that accumulated and bring their oxygen level back up. But sometimes there can be an overshoot. They can blow off too much CO2, and that's where you get this little central component. But by the time the apnea or the CO2 rises back above apneic threshold and it stimulates their breathing, their airway is closed off, and that's where you get this obstructive component. So you'll typically see mixed apneas in patients that are very severe with their obstructive apnea, or they just are too much of a response to the event, where they're hyperventilating too much, creating that bit of a central component. I know you'll ask this. It's never opposite. It doesn't ever start obstructive and then go central. It doesn't happen. It's always central and then obstructive. Hypopnea. So you're looking at your nasal pressure signal. You need to have a drop by about 30% that lasts at least 10 seconds, and in addition causes a 3% desaturation, or the event is associated with an arousal. Now this second part of it, the event is associated with an arousal, is a new updated version to all of our ASM manual rules. Some labs do not go by this. You've got to check with the lab that you're at. Some labs don't count an arousal as being enough. Some of them still require that you need a 3% desaturation. Some of them, depending on the patient's insurance, still use the old rule where you need a 4% desaturation. So that's why it's so important when you get to the lab to determine, especially if you have like a split night where it determines whether or not you're going to implement the CPAP titration, Well, what hypopnea rule are we using? What do you guys go by? Because I think it's Medicare even still requires a 4% desaturation for the hypopnea rules. Okay. So when you look at all of the scored reports, you'll notice on the cover it actually defines what hypopnea rule was used. Hypopnea rule A, so that was the 3%. Hypopnea rule B, 4% desat. And then this one has the option of to also score an arousal. So if there's an arousal at the end of the event, you can do that. You can score, and there's no desat, but there is an arousal, but there's a 30% drop in airflow, you can score the event. This one does not. Rule B does not have the arousal component to the rule. Just 4%. RERA, respiratory effort related arousal. So basically what happened is if you guys remember, as part of the AHI, you're looking at the overall number of apneas and hypopneas. That's what they used to go by to diagnose a patient with having OSA. But there was a huge issue of upper airway resistance going on, that these patients were having respiratory events, but they just didn't quite meet the criteria of an apnea, where they had no airflow for 10 seconds, or they didn't meet the criteria of a hypopnea, where they had that desaturation. But there was still some very obvious sleep disordered breathing going on, just not enough to meet the criteria for these overt respiratory events. That's why they developed the RERA, and that's why it's counted in as the part of the RDI. And that's why we go off of the RDI to establish the patient's diagnosis and severity for sleep apnea. So a RERA is, again, the respiratory event has to last at least 10 seconds, but you have a very clear issue in their breathing, where either you're seeing kind of a flattening or squaring off on your nasal pressure transducer. One of the things as we continue on next year, as you guys get more comfortable and familiar with reading your signals, is our flow signals, the shape of them can give us a lot of good information as well. And so when you see, the thermal signal, it doesn't really, you can't see much. But the pressure transducer, you can see the start to squaring off of the signal. And that means that the patient's getting some upper airway resistance as they're inhaling. So if you start to see that kind of squaring off or flattening of your either your rip belts or your nasal pressure, and this kind of, or you have a lot of snoring, and sometimes you'll see the snoring severity increase, that results in the patient waking themselves up, that's the definition of a RERA. Part of the definition is you have to have an arousal. You don't have to have an arousal to score a hypop or an apnea. You do to have to score a RERA. Okay, so basically, how I explain obstructive sleep apnea to the patients is it's like a spectrum disorder, in that you can have any different type of event, a number of different event types that count towards the diagnosis. On the severe end would be an apnea, where you stop breathing completely. On the milder end would be your RERAs. I don't say RERA to patient, but that's where you're having more of a snoring and upper airway resistance that's causing you to wake up. Midline of the spectrum, kind of between the two, would be your hypopnea, where your airway isn't closing up completely, but it's closing up enough that it's going to cause your body to not get the oxygen that it needs, which causes that desat. Does that make sense? But all of them are components of the sleep disordered spectrum, that obstructive sleep disordered breathing. Here is, again, a recap of the definition. This is straight from your Fundamentals 1 lecture. Risk factors: weight, Mallampati, class 3 and 4. Men are more at risk. Large neck size. Is this all coming? This should not be new. Remember, this is all part of the stop bang: the neck size, gender, weight, age. Older you are, the floppier things get, the worse your apnea is. History, so that could point towards more of an anatomical predisposition. Gastric reflux, anything that's going to cause your airway to be more narrow, so large tonsils, large tongue, small jawbone, deviated septum, allergies, retrognathia. So the small jawbone, that's where you get that retrognathia or micrognathia, that like really weak looking chin, you know, like the like Mama June. right? Central apnea, idiopathic, meaning causes unknown. It could also be brought on in higher altitude, so the change in the partial pressure of the atmospheric pressures can cause either periodic breathing or central apnea. Anything that's going to affect the brainstem, which is where your respiratory components are within the pons and the medulla. Anything that can impact your brain, neurodegenerative illnesses, Parkinson's disease, medications, Cheyne-Stokes. Cheyne-Stokes is, you guys remember from Patty's class, is that crescendo-decrescendo pattern of breathing, very commonly associated with CHF, and they found the severity of the Cheyne-Stokes breathing correlated with the severity of the patient's CHF. When they got to be more end-stage CHF, the worse the Cheyne-Stokes was.